Hello, everyone, and welcome to our webinar, Innovations in Cardiac Care for Hospice Patients. My name is Lauren King, and I'm the Community Education and Caregiver Academy Manager at Coastal Hospice. Welcome to our Caregiver Academy. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Atlantic General Hospital, Talbot Hospice, Dorchester County Health Department, Riverside Home Health and Hospice, John B. Parsons, Tidal Health, Encompass Rehab, and many, many more. It's wonderful to see everyone today. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleagues, Alejandra and Joy, pop up in the chat box to address or help with any technical issues. I want to thank you for your patience ahead of time should we have any. I'll also come back at the end to discuss the program evaluation. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. Our webinar today will be moderated by Lauren Blair, Community Relations and Development Manager and Caregiver Academy Moderator at Coastal Hospice. Lauren has more than 15 years of experience in the healthcare field. She holds a master's degree in social work from Salisbury University, is a licensed master social worker in the state of Maryland, a licensed clinical social worker in the state of Delaware. Lauren serves on the board of directors at the Grace Center on Maternal and Women's Health, is a subject matter expert for the Dementia Care Resource Initiative through the National Partnership for Healthcare and Hospice Innovation, and a nominee of 2023 Women to Watch of the Chesapeake. Lauren, I'll hand it off to you.
Thank you for that introduction, Lauren. I am pleased to welcome Dr. Stacy Cottingham here today. But before I do, I'll share with you the disclosures for those of you receiving continuing education credits. For physicians, this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accredited Council for Continuing Medical Education through the joint providership of Tidal Health Peninsula Regional and Coastal Hospice. Tidal Health Peninsula Regional is accredited by MedChi, the Maryland State Medical Society, to provide continuing medical education for physicians. The Continuing Medical Education Committee of Tidal Health Peninsula Regional designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurated with the extent of their participation in the activity. The planners, speakers, and the Continuing Medical Education Committee of this educational activity declare that they have no relevant financial relationship to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used on or by patients. For nurses, Tidal Health is an approved provider of nursing continuing education for development by the Maryland Nurses Association, an accredited approver of the American Nurses Credentialing Center's Commission on Accreditation. In order to receive contact hours provided by Tidal Health, you will need to attend the entire course, missing no more than 10 minutes, and complete the following course evaluation with post-test. The speaker presenting today does not have any financial disclosures to report. And for social workers, Tidal Health Peninsula Regional is authorized by the Board of Social Work Examiners in Maryland to sponsor social work, continuing education, learning activities, and maintains full responsibility for this program. This training qualifies for one Category 1 continuing education unit. We are very excited to have with us Dr. Stacy Cottingham today. Dr. Stacy Cottingham, PhD, MSN, RN, CHPN, is our Director of Quality Improvement and certified in hospice and palliative nursing. She has over 30 years of experience that spans acute care and outpatient services in cardiac care, critical care, oncology, and for the last 11 years in hospice care. She has served in both clinical and leadership roles at Coastal Hospice, taught as an adjunct at Salisbury University, and previously directed a local nursing workforce program funded by the Robert Wood Johnson Foundation. She was awarded the Outstanding Pathfinder Award for the Maryland Nurses Association in 2009. Welcome, Stacy.
Thank you, Lauren. Glad to be here.
So, Stacy, what are we going to be looking at today?
Sure, Lauren. We're going to go over 4 main objectives. First of all, we're going to walk through the signs and symptoms of decline in cardiac patients. We're going to review some of the services that are provided to cardiac patients and their caregivers in hospice and palliative care that demonstrate improvement in healthcare quality. We're going to describe some of these elements that can be included in a comprehensive plan of care that can demonstrate the collaboration in the process of healthcare quality improvement, and then stating what the process is for referring a patient to the cardiac program at Coastal Hospice.
A lot of great information here today. So first, we're going to talk about the silent pandemic. What is this, Stacy?
Yeah, the silent pandemic. As you can see from the slide, heart failure affects 1 out of 3 adults, and it kills 1 out of 4. It's the most of any disease. And COVID-19, it increased premature deaths due to patients having heart disease, but not seeking treatment. And on the average, only 50% of heart failure patients who would qualify for hospice care are enrolled. And among people of color, it's a much lower percentage. And on average, only 5% of patients discharged from hospitals with heart failure are enrolled in hospice care. And the average lifespan of a heart failure patient, it's 3 years. And that's heart failure defined as the squeeze, the heart pumping at 20% or less of total efficacy. As a study of about 120,000 Medicare beneficiaries in the American Heart Association get with the Guidelines Heart Failure Registry. Hospice discharges, they did increase a little bit. They went from 2% in 2005 to 5% in 2014, but we really have a long way to go.
Absolutely, absolutely. What CMS data are we seeing here?
Yeah, when I reviewed our medical record, looking at the CMS data in 2018, our most recent that we had at the time, the state of Maryland overall CHF is 12.5 of the decedents. Nationally, it's 13 point, almost 14%. And when you're looking at our state data and how our lower counties are impacted by heart failure, Somerset is number 5 in the state at 14, well over 14%. And then Dorchester, Wycomico, and Worcester with the numbers listed there above. So we have a lot of work to do.
Sure, absolutely. It's interesting to see the numbers for the 4 lower counties compared to Maryland, compared to the national numbers, especially. How about cardiac patients right here at Coastal Hospice?
Well, in a review in 2022, almost half of all the patients admitted to Coastal Hospice during that time frame in the slide prior were in the diagnosis group involving the circulatory system. And then taking that grouping, about 47 patients or 35% in that circulatory diagnosis group were admitted specifically with a heart failure or cardiomyopathy as their primary hospice diagnosis. So you can see the impact locally and what we're able to serve at this point.
The prevalence is very high. Yes. So what news are we seeing these days with cardiac care?
Yeah, the big news. There's this new wave going through. It's looking at disease-specific care when it comes to hospice and palliative services. And the new way to support patients within those different high-risk diagnosis group. There's a collaboration between the NPHI and American Heart Association, really taking a closer look on the type of specific care given to the stage D New York Heart Association class 3 and 4 patients. So we can look to reduce the emergency services utilized with this patient population, reducing the overall hospitalization and increasing their home care type of services for advanced heart disease with hospice care. And we have on our website a program guide that walks through the services and the type of education provided to the patients and caregivers.
Lots of great information on that website for sure. This next chart is very interesting. I know we see a lot of cardiac patients in and out of the hospital.
Yeah, and this is something that we saw in my years in acute care working in cardiology. The cycle of heart failure and the people, the bounce backs. One of the stories that we would share is the ham stories. So if there's a holiday or a special celebration going on, we could almost guarantee the amount of heart failure patients that we'd see due to the salt intake and eating the ham. They'd come into the emergency room or a visit. They get what they call draining the tank. So they're given a lot of medication changes, including diuretics, discharging them home. They're now diagnosed as a chronic heart failure. They may have had an episode of acute on chronic. They're seen post-hospitalization in their provider's office. They make a few more changes, increasing the amount of diuretic medications, and they come back into the emergency room after a period of time of either non-compliance with their medications or non-compliance with their diet, or just the overall trajectory of disease is progressing.
The difference in the structures that we see here?
Yeah, there's a couple of different ways of looking at heart failure. And the review of a structural heart disease, these pictures kind of give a pretty good, very basic look of this. One way, the first one in diagram A, is the weakened myocardium. So a patient may have had some disease or illness processes or valvular disease that has caused the muscle in that LV, the left ventricle, the main pump of the heart, to weaken. So it's a little boggy. It's not able to really give a good squeeze to pump the highly oxygenated blood back into the body to help provide the oxygenated blood to the rest of the systems and the organs. Now, the second one is a thickened myocardium. You can see that pinkish area represents the amount of muscle. Now, when you work a muscle a lot, it builds up, and there may also be some scar tissue in there. And therefore, the amount of blood that's able to be pumped, that chamber, the left ventricle, is smaller. So the volume of blood that's able to be pumped into the rest of the body is much less.
How about let's move on to the cardiac assessment. Let's look at how the cardiac assessment patients do with a cardiac diagnosis. But first, I think you have a question for us, right, Stacy?
I do.
Our first poll question.
So patients have to have their pacemaker turned off when they start hospice services. Is that true, false, or you don't know?
We'll give everybody a few seconds to answer that.
Now, I do want to say, while people are answering the question, that with cardiac disease, these conditions, they significantly reduce the quality of life of the patients and subsequently, you know, the spouse or the family member that's with them. It requires ongoing treatment. It's usually progressive and associated with high mortality rates. The progression of many of these conditions, the different types of cardiac conditions, from chronic to advanced and to end stage, it can be unpredictable and marked by worsening symptoms. And that can result in this recurrent hospitalization. But involving palliative care services or hospice care services can drastically improve the functional status and overall quality of life of these patients. All right. So patients have to have their pacemaker turned off. False. Patients do not have to have their cardiac pacemaker turned off. And we'll go into that a little bit further. So thank you for all that responded.
Stacy, what happens when someone has a cardiac diagnosis and is referred to hospice care?
If they're referred to hospice care, we send an entire team out to assess the patient and the caregiver. Because again, the hospice team, when they go in, we're not just assessing physical, emotional, we're also the teachers on how to teach the caregiver how to care for the patient, how to assist the patient, and to be a conduit of communication between both the patient and us as assisting them in their caregiving. But there's several different things that we look at when a patient comes onto hospice services. We really want to stay on top of symptom management because, again, the goal is really for a patient and family to stay home in their care and not to keep going in that cycle back to the hospital. The documentation that we do put into our electronic medical records really gives us the additional evidence to help support the ongoing care of hospice and to communicate with the specialists that referred. So in the hospice admission and ongoing visits, we're looking at vital signs, we're checking weights, if they're able to stand, abdominal girth. And that's a big question among our staff when we were training, is abdominal girth. Because as the heart starts to fail, oftentimes the fluid will back up into the liver, the portal hypertension, and then that in turn will have a development of ascites, or the swelling in the abdomen. So there are certain patients where we want to start doing some abdominal girth just to measure the amount of stress that's being put onto the hepatic system. Leg edema, we see that a lot in our heart failure patients. And what are they using to manage it? Is it TED stockings? Is it ACE wraps? And regarding their appetite intake, of course, if they don't feel good and their electrolytes are off the wall, they're not going to feel like eating and drinking. So finding out where they are, and so that we can help find them some pleasure and joy in their appetite, and use sometimes medications to help support that. and output. Cardiorenal syndrome, of course, is a big thing. As the renals start getting impacted, the decrease in the urinary output, there may be some changes in blood pressure where they're not perfusing to the renals. So these are all different key things that we're looking at in our assessments. Heart sounds, we're not trying to assess and identify any new clicks, rubs, etc. But just knowing what's normal, what's abnormal, and if there's a change, what we need to report up to our medical staff for any kind of changes that we need to make in their care plan. Respiratory, what's the quality of their breathing? How are they sleeping? Is there a cough? Is it dry? Is it wet? Or any other diagnosis like COPD, interstitial lung diseases, asthma, or anything like that that may be impacting, co-impacting their cardiac status. Presence of jugular vein distension is a key indicator as to whether or not the person is starting to build up some fluid, and if we need to take quick action in the home to help to alleviate that situation. Medication review, of course, medication review is huge, creating that balancing act, and we'll go into some more of the medications here shortly. And then cognition, mood, and behavior. They don't feel good. You know, they're not going to want to be as participative in quality of life activities that they once did. So trying to help them work through those things.
This is a lot of great things that Coastal Hospice is able to do to help these patients to succeed and stay in their homes. For sure. I know another thing that we do often is advanced care planning. I'll let you talk about this.
Yeah, advanced care planning, those conversations are key. And if they haven't been done in either the primary provider setting or in a hospital or et cetera, our team, whether it's our palliative care team or community palliative, or if it's our hospice team going out, advanced care planning is key to knowing what the patient's desired wishes are and what their treatment preferences are. And we use a couple of different ones. There is a one that's out there for other organizations may use is Respecting Choices. It's a whole course with instructors. But 5 Wishes is one that we use. And then we also have the Maryland website has the advanced care planning, and we use that one most often with the hospice patients. But Lauren, I think you have some more information on the 5 Wishes.
Absolutely, absolutely. The 5 Wishes is a great, very easy to use pamphlet that or a big kind of workbook that we do, and we are happy to come out. We actually are been trained to provide education on these and to help people with filling those out. So certainly if anyone is interested in having us come to their organization and speak about 5 Wishes and assist people, we would love to do that. We've been to a few of the senior centers and health departments, and so if anybody's interested, we would love to do that. There's more information on our website as well. Let's move into what kind of cardiac care medications are available for palliative and hospice care.
Let's see, and do we have a polling question for this one? Okay. So patients have to discontinue their medications when they come into hospice services. Is that true, false, or you don't know? And while you're answering that question, I do have something that was hot off the press. I was just reading last night. There was actually a new publication that came out in the journal Circulation, Cardiovascular Quality and Outcomes. And the American Heart Association released a new scientific statement stating that implementing patient-centered palliative care therapies, including prescribing, adjusting, or discontinuing medications as needed, may help control symptoms and improve quality of life for people with heart disease. And that they went in further saying that a palliative approach can be integrated into the medication management of patients really at any stage of their heart disease, from chronic to stable to advanced disease. Excellent. Yep, the answer is false. Patients do not have to discontinue their medications when they come onto hospice services. Thank you.
That's a great question. I get that question a lot in the community, and people are always surprised that that's not how it is. So it's great.
So what we'll do here, Lauren, I'm just going to to touch through some of these. I think the group that we have that's on the call, I think they know them pretty well.
Great. So ACE inhibitors.
So on the left-hand side of the screen, you'll see as we work through these medications are the most common ones. It's not fully encompassing of everything that's in that group, but you can see the list there. And then teaching with the patients and caregivers when it comes to the ACE inhibitors is really what it does for them, helping to lower their blood pressure, to decrease the amount of work on the heart. But some of the side effects, and if they've been on it, they know it, it's a dry cough. Dizziness if they get up too quick, some constipation, a dry mouth, and to take their medicines as directed, typically an hour before meals.
What about the ARBs? Look at those.
Yeah, the ARBs. The one I most often see is Cozar. Sometimes I see Diovan, and it works very similar to the ACE inhibitors, but it avoids some of those side effects like that cardiac cough. But again, you know, it's the sitting to lying, the orthostatic hypotension, and just helping to teach them not to do sudden changes in their feet, in their lying, sitting, standing.
And how about the ARNIs?
Yeah, Entresto. That's one of the newest ones, and it is an expensive medication. However, with that, the reason being it's a combo drug. It takes valsartan, which is an ARB that was listed prior in the prior screen. With a second drug, which is a hormone type system, works on that, which releases BNP to help reduce both the lowering the blood pressure, but also helps to eliminate increased salt and helping with reduction of fluid.
I know we're flying through these, so if anybody has any questions, feel free to type us in the chat box, and we'll certainly answer. How about antiplatelets?
Yeah, antiplatelets. We like to try to transition patients over to an aspirin product as appropriate, because of course every patient is different, and the reason of being on a blood thinner for each patient may be a little different. But the reason for it is because, well, for two reasons. One, the implication of cardiac disease on the liver. So their liver function tests are going to be a little wonkers, and they also might have some changes in their clotting time. So we need to be mindful if they're on some of those higher dose type of antiplatelet medications. But again, working with them and the referring provider, if the patient elects that person to be a part of their plan of care, to see what the best mode of therapy is, because it's a risk of these patients with their blood pressure and their heart rate being, you know, as they go down the end of their trajectory of the disease process, to fall. And to fall and have one of those higher intensity antiplatelet medications on board and have a head bleed versus, you know, having bump on the arm or something. So these are all risks that we have to take a look at each patient individually to make the right choice with them.
How about beta blockers?
Beta blockers helps to lower the blood pressure, slows the heart rate. So we just, you know, measure their vital signs just to see if we need to decrease some dosage, but not to stop that medication without working with their medical team to make sure what's the right move if that were to be discontinued or deprescribed.
And how about the benzodiazepines? This is interesting because I see those are listed, they're anxiety medicines.
Right. When you start to have chest pain, shortness of breath, you get anxious. And one of the key factors of quality of life is sleep hygiene. So in getting a baseline as to where they are in sleep and introducing one of these medications, whether in the their specialist or primary provider setting, or if in a palliative or in a hospice setting, it can help complement other therapies that the patient is currently on. And if they sleep better, they feel better, and they can do more activities that bring them joy during the day.
How about cardiac glycosides?
This is an old tried and true. This is the one I have growing in my backyard garden. Digitalis, old medication, helps with the contraction, the squeeze of the heart. There's a couple of side effects though, and typically a patient gets blood work to monitor what their dig levels are. And once you get into hospice care, we start to move away from those type of interventions, but we monitor symptoms. And and of course, there may be a time where the patient, it's no longer therapeutic for them and the side effects are much more significant than the effects of the disease. So we take all of this into consideration when we look at the patient's complete plan of care.
I know we hear a lot about diuretics in cardiac patients.
Yeah, diuretics are key. If you have too much fluid, then backs up into the lungs, backs up into the body, into the other organs, and the patient does not do nearly as well. So Lasix is key. Of course, I'm monitoring what their output is and how their kidneys are functioning, but there could be where the patient's on Bumax or Demodex. And then, of course, there's also utilization of Zaraxolone to help promote the diuretic impact of the other medications. So if a patient has one of these questions, if a patient is referred has an access device, because they have been getting maybe a Lasix drip in the hospital or something. This is a question that recently had come up. We encourage them to keep that PICC line if they go home in case we need to administer Lasix IV to help them through whatever kind of intermediate crisis they may occur in the home setting. We can do that. So I just wanted to put that out there as a more recent occurrence. But with these patients too, we try to encourage them to take their water pills, as they call them, before 3 o'clock in the afternoon, because again, sleep hygiene, we don't want them up going to the bathroom in the middle of the night as often. But we also monitor through symptoms as to the level of potassium and do dietary education to help support them.
I love that you brought up, Stacy, that we can do that IV Lasix right at the home. That's something that people are excited to learn. Sure. So how about the MRAs?
Well, the MRAs, we see those, but not a whole lot. But this is also to help get rid of some of that excess water, so to speak, making it easier for the patient to breathe, and taken in conjunction with some of the other diuretics to help that patient pull off some more fluid.
And moving on to the comfort kit, tell us about what is in the hospice comfort kit.
Yeah, I'm glad we're bringing this up. This is a total game changer for these cardiac patients and how we individualize and specialize the care for this population. When patients come onto hospice services, this isn't for the palliative patients, but when they do transition onto hospice care, we have a comfort care kit that goes out to every hospice home. But with cardiac patients, there's some additional medications that are put in there to help alleviate the signs and symptoms of fluid overload, additional anxiety that also can come with chest pain, shortness of breath. So the medications that are in addition, and this is in several of the cardiac programs across the nation, because this is a national program that we're bringing here to the Eastern Shore. The metolazone, we have that for dyspnea and fluid overload. And again, these are if there's an emergency or an urgent on call in the middle of the night, because we don't have any pharmacies that are open 24/7, only on an emergency basis. So these are little kits to keep in the home. Lasix injectables, which is a huge paradigm shift. They are ordered so they can be just subcutaneous if the patient doesn't already have a pre-existing line, or they can, if they don't want, patient doesn't want injections, we can get oral, and nitroglycerin, because you just don't know how fresh it is in the patient's home. And again, the lorazepam and the morphine to help with the palliation of symptoms.
That's incredible. They have their own kit ready to go if they need it. Makes things a little easier. So moving on to the inotropic therapies.
Yeah, inotropes are not so common. There are hospices all across the nation that do accept inotropes at different varying levels of whatever the patient's trajectory is or what their goals are. So inotropes can be used either in continuous or intermittent therapy for end-stage CHF. Typically, what we see are low-dose dopamine, dobutamine, or milrinone. And these help with the contraction of the heart. Helps with improving cardiac output. So you're thinking that's more good oxygenated blood to the brain, increases the renal blood flow. and reducing the overall symptoms of CHF. Of course, and in low doses, it does help with urinary output. So with these kind of patients, it does take a lot of planning. Just like if we were to bring a vent patient into a home for extubations, we have a whole team that kind of rallies around this because of the level of risk and the level of education with the patient and family and the amount of psychosocial and emotional and spiritual support that's needed for these families.
We're going to move into cardiac devices next, but before we do, I think you have another poll question for us.
See, hospice patients do not keep their primary provider or specialist. True, false, or you don't know. And while you're answering that one, for the cardiac program at Coastal Hospice, I just did a quick review. Looks like about since maybe end of January into February, we've had about 50 patients go through at different levels of their disease. And so very excited to be able to be out there and be with these patients to help support them and to help improve their quality of life and keep them out of the hospital. And the overall goal is really to decrease the amount of emergency room visits. I'm looking at nationally, the group is looking at 30% reduction. So even, one person to keep them home to improve quality of life is a huge game changer.
Absolutely. That's exciting news.
And false. Patients do keep their primary provider or specialist. Of course, this is all a patient-centric, patient-driven type of service. So if the patient wants the cardiologist or the pulmonologist to be involved actively in their plan of care, we will do that. Primary care provider too. It's a lot of communication and a lot of coordination, but we will do as the patient would like.
Absolutely. All right, moving into cardiac devices. Can you tell us about these pacemakers and defibrillators in hospice patients?
Sure. AICDs and pacemakers. The pacemakers function is to correct an abnormal rate or rhythm. We don't turn off the pacemakers, and the degree of dependency on the pacemaker, it really varies by patient. And for a patient that's dependent on the pacemaker, deactivation would cause severe discomfort, and it would negatively impact their quality of life and possibly hasten death. So we don't touch the pacemakers. But the defibrillator, the premise of that is to restart a heart that stops due to a sudden cardiac event. So for that, patients can come on with their defibrillators active, but we work with the patient and family, and we stay with them as to what their goals are. But if they do want to keep that on, we keep a magnet in the home so that if the occurrence happens, then we have a way to help to minimize the distress.
Good to know. And what's the LVAD?
Well, an LVAD is a very highly specific high-risk device for patients, usually as a bridge towards a transplant. We have LVAD centers up in Philadelphia, Baltimore, DC, down Norfolk, not here in the shore right now, but it's very, very specific to a patient, and it's an external device that essentially takes the place of the heart. The hospices don't manage the device itself. The patient and family manage the device. And then we assist with any of the symptom management, and we would have very close collaboration and communication with their LVAD center. There's ongoing PTT-INRs in the home. They have extra battery packs. And then there's also the discussion of the planned deactivation of the device. So again, just like with inotropes, it's a very self-limiting kind of thing. LVADs are the same. So the whole goal is to go home and to pass away in the security and love and comfort of their friends and family in their home.
Absolutely. I have a question from the audience for you, Stacy. It says, Bet Long asks, for family caregivers or patients deciding on hospital at home versus palliative care or transitional care, how do you help the family decide? How do you help them decide what route to go?
Well, it's a conversation, and we encourage the patients and families or the referring partner, anybody can call Coastal Hospice or any of the hospices to get an informational. And the information, if the preference is just by phone, we can just do a discussion over the phone to describe the services, or we can go out into the home and at the time, having that interpersonal conversation as to what their goals are. So really that's what it's all about, or the goals of the patient and family. And we'll get into a little bit more of the referral process a little later, but that's a really good question.
Absolutely, absolutely. And moving on to how we monitor cardiac symptoms in hospice.
Sure. With monitoring cardiac symptoms, it's all about teaching patients and families.
Wonderful.
And how we do that is through our patient and caregiver guide. Now, the patient and caregiver guide is for both our palliative and hospice patients. It's an education tool. It has a lot of information on signs and symptoms. It's got reviewing dietary education, and mostly it's just to empower the caregiver and the patient so that they have control over the what they're seeing among themselves and what they need to do for next steps.
And again, that guide is available right on our website, so you can check that out and hopefully can help you and others with any information you need to know. So what kind of other tools can we use to empower patients and caregivers?
Yeah, the tools that are in there, there's places for them to write things down. In a care plan, there's goals and there's interventions. Well, what kind of interventions would the patient and family like to have as part of their plan of care? So as they're living life and thinking about what they want to do, they have a place in this guide to be able to write that down. And that's an awesome communication tool between the patient caregiver and the team that's taking care of them, or if they want to take it to their specialist or their primary care provider to review with them too. It's really part of like an informal plan of care, so to speak. And it gives them tips and tools as to what to do if they have changes or increase or a new onset of anxiety, chest pain, swelling, harder to breathe, the dyspnea, and some of the other symptoms that may come during their cardiac trajectory of their disease process.
Some really great tools for our cardiac toolkit, so to speak.
Mm-hmm.
So I see a few stages for us. So doing well, the green zone. Tell us about that.
Yeah, and this mirrors with one of our local hospitals, a regional system has a CHF guide that goes out to patients and families. So this kind of mirrors that. So for patients that have been in the hospital or have gone through CHF clinics or something, or cardiac rehabs, they probably have a very similar book. So this just takes that idea a little bit step further because a little further down in their disease. And we have it mirroring that. So it's green, yellow, red. And for the green zone, they're doing good. They feel okay. They really don't have any symptoms that are out of control. They're maintaining their desired activity level, and they just continue on their current plan of care.
Then how about moving into the yellow zone? That's a bit of a bad day.
Yeah, yellow zone, they're not quite sure, what's going on, but things are different. And it's really about how they feel. Is there a gain or of weight or a loss of weight because of their appetite? Is there a new cough or a change in the type of cough? Same thing with swelling and shortness of breath and orthopnea. Were they sleeping in bed with maybe 2 pillows and now they're having to not sleep as long, or adding an additional pillow, or any new symptom or anxiety starting? And if they are in Coastal Hospice programs, if they're in the hospice side, we have staff that can be reached 24/7. Medication can get reviewed and changed in the moment. We can discuss their weight, discuss other issues with their interventions that need to be changed. And overall, it's discussing their goals of care, which is staying out of the emergency room in the hospital and getting care at home.
And this is such a great example of what the program really can do, is to help people when you have these issues in the middle of the night. You can call us when you're a patient.
And then,
And-
oh, sorry. I get the red zone. This
Yeah.
is urgent time. So what are they saying and what are they feeling at this point? There's an increase in symptoms, a significant weight gain. They gained 5 or 7 pounds in the overnight. Unrelieved shortness of breath, or they're starting to experience shortness of breath, just not doing anything. They're at rest. Unrelieved chest pain, or those 3 nitros and it didn't work. They're starting to have pain at rest. They don't have to even do anything and they're starting to get chest pain. Starting to wheeze, which could be an indicator of starting up with some fluid somewhere in their lungs, and having to sit upright, or starting to sleep in the recliner. That's something they don't really think about, but that's really key. Starting with confusion, because they're not perfusing up to their brain to start to get some confusion, or the buildup of the metabolites from their kidneys and their liver, and then anxiety. So what do? We have a hospice hotline. Of course, that's a 24/7 number to call, and a hospice nurse is on the other end. And they'll start walking through the process of triage and then dispatch an RN to go out to the home to see what additional things that we can do in the home to help palliate those symptoms. Now, in-home management, that can be done there if they want to stay at the home and treat that. That's a continuous care, or they have the option if they qualify and we get the order from our physician to go to one of our inpatient units for what's known as a GIP. So those are types of different levels of care. It's just really to improve and get a patient through that crisis moment. And again, even in the red zone, yellow zone, green zone, discussing those goals of care.
Absolutely, absolutely. So again, 24/7, that's just amazing to be able to have that in your back pocket in these times of need, for sure. We talked about the patient caregiver training. We talked about that 24/7 support. How else can Coastal Hospice help?
So how does Coastal Hospice help? So then the question asks, so how do we refer to find out? Even if you're not sure where the patient is in the trajectory of their disease, they just know it's advanced, they've had 3 ER visits, and they look like they don't want to keep going back and forth to the hospital, or even if they do, give us a call and we can help navigate to see what program is best meets the needs of the patient and the family at that time, whether it's palliative program or if it's for a hospice program. So again, just call us and we will put you in touch to the access, otherwise known as admissions department. It'll get, the records get reviewed by our medical director to look for evidence in the documentation of hospice eligibility. And that's for the hospice side. Access team, the admission nurse will collect patient information, set up the appointments, to do the information evaluation and admission of the patient and family. Because again, we're not just patient, this is the caregivers too. And the hospice medical team, they do have a day-to-day oversight management of the patient's care, but this is also done if the patient selects a primary provider, a cardiologist, pulmonologist to be a part of this plan of care. Then we work in collaboration with and keep them involved and communicated with. So the interdisciplinary team will go out within the selected time frame. The patient will be assigned, patient and family will be assigned a dedicated registered nurse case manager, a medical social worker, and a chaplain. The patient and family desire an aide will collaborate on the level of frequency of an aide to go out maybe once or twice a week if the patient requires some assistance in just personal care. And then of course our volunteers, our hospice is, the hospice is required to have volunteer services because we started as a volunteer organization, and then any other therapies that may be needed to help to individualize that patient-driven plan of care. And again, ongoing discussions with the patient caregivers about their goals.
Terrific. Let's move into cardiac specific clinical algorithms that you can share with us.
Yeah, so we have following algorithms. It's a step-by-step process to help guide the clinical assessment, and the nurses and the rest of the team to direct it says the client management of a patient experience and symptoms. So there's different ways that our American Heart Association has approved these algorithms, It's a great communication tool for the nurses with the providers when they're out in the home and the patient's having a crisis moment using the SBAR. And the dyspnea, it's of course shortness of breath, how we're going to manage that using these evidence-based algorithms. There's another one for chest pain, and then of course fluid overload.
Move on to the cardiac care plan. Tell us about those for hospice and palliative patients.
Sure. I'll just breeze through it. The participants will all have a copy of the slide so that they'll can look at it to see what kind of individualization a patient and family can have as it relates to the cardiac aspect of their hospice care. Of course, everything is defined by the patient and family, and we walk alongside. So wherever they are in the trajectory of their disease, we take them where they are and to help educate and move them forward into I guess a level of more comfort and ease and a higher quality of life.
There's lots of different interventions that we can use with these patients. It's great to see.
And as you'll see, some of the interventions that are listed here are part of the physical aspects of what our staff will do when they go out there, depending on the patient and the family's needs, the types of educations that are provided, utilization of oxygen safety. So it's very comprehensive, and this is just one aspect of the cardiac specific areas of a whole comprehensive plan of care.
Great. I love that you mentioned that it's really patient and family driven, and we're just walking alongside of them in this. Moving on to the why refer. Why should anyone refer to Advanced Cardiac Care Program?
Yeah, this is really it's a nationally recognized and endorsed program, and this is something that has been needed in this area, especially as what we see for patients that are end of life and the diagnoses that they come in on. To have something that is evidence-based driven is really incredible for our lower shore counties. There's the frequent contact by the home hospice RN with the RN case manager or one of the on-call or extended services nurses that have received specialized training to evaluate and manage the cardiac symptoms. Being part of a team, doing home visits that have this cardiac training, helping to provide care so that it prevents them from having to leave the comfort of their own home. Medication to effectively manage and keep them out of the hospital, including the parental furosemide, the parental Lasix that we talked about. Specialized cardiac protocols. That way our team is right on it when it comes to monitoring changes and preventing symptoms from worsening. And the additional supportive care visits with our chaplains and social workers, the CNAs and volunteers, depending where they are in their decline in their disease process.
Perfect. Now we know why, who, when, and who should we refer?
Yeah, this the patients that have been going in and out of the emergency room, you know, that cycle that we were talking about at the beginning, breaking the cycle. And when the patients are tired of going to the hospital, or they get to the point where they really can't get out of the home for provider visits anymore, that's a good time to give us a call. They're optimized on the modalities, the different kinds of therapies, whether it's medical device, and what we can do to help improve or to maintain their quality of life so that they can experience the joy. So some of the things that we're looking at, of course, the shortness of breath and chest pain, the edema, fatigue, they're just tired, persistent cough and congestion, the changes in their appetite, their anxiety. So these are the types of things that we look at when it qualifies a patient for the 6 month or less. Again, 6 months trajectory is independent on each patient. This program is really intended not for those that are to only have 2 days on hospice services with them, but we want to improve more than that. We want to have time with them. We want to have conversations with them, and we want to have time to teach how to improve their current status and to prepare for next steps.
Absolutely. There's so many ways that we talked about that keep patients in their homes and comfortable. So we want to encourage that for sure to utilize. And then how do we refer?
Yeah, it's very easy. We try to make it as absolutely easy as possible. If a patient is inpatient, it depends on where their location of hospital. If they're here locally in Title Health, we have liaison that's there. That can get these referrals through the Epic system. The hospital discharge planner gives a call, especially and call us especially on the weekends. But otherwise just call. We have access to be able to pull records once the referral is made, to give us permission to do so we can start an intensive record review and help to pull the pieces together so that when the patient and family is reached out to about the referral, then we can make those next steps for the patient and family and the referring providers as easy as possible.
And anyone can make a referral. It doesn't have to be a physician or a nurse or a social worker. It can
Correct.
be family and friends, right? Yeah. And you can, of course, visit our website for more information on the cardiac program and our other programs as well. I want to take a minute to see if there's any questions from the audience that we have not answered for you yet. Please feel free to type those into the chat box now, and while we still have Dr. Cottingham with us, we can explore those. I don't see anything coming through, but certainly if you think of questions afterwards, you'll have our contact information. You can email us, call us, and we'll be happy to help in any way. Thank you, Stacy, for being here with us. I greatly appreciate it. It was awesome information to hear today. And Lauren, I'm going to turn it over to you.
Thank you so much, Dr. Stacy Cottingham and Lauren Blair, for this presentation on a topic that may be relevant for many. And thank you for everyone that's joined us today. We hope the information was useful to you. We encourage everyone to attend our next webinar on Tuesday, September 10th at 12 p.m. Mark your calendars. The topic is approaching the end of life, signs and symptoms. You can visit our website to register. There will also be CEUs provided for that. To wrap things up, we ask that you take a couple of minutes to fill out a short survey. By filling out this survey, you will allow us to provide the continuing education credits to you via email, and your feedback will help us bring relevant programs to you, your practice, and those you care for. To complete the survey, visit the chat box. You will need to click on the appropriate link for your field or scan the QR code on the screen now. You will be able to print your certificate of completion immediately after completing the survey. Additionally, you will receive a follow-up email later today continuing the links to the surveys. Please remember that you will need to fill out the survey within 24 hours in order to receive the continuing education credits. Also, I wanted to share with you all that the certificate is presented to you via a link from the SurveyMonkey. The certificate will not be an email attachment. I do know in the past that we got questions about that. This presentation was from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. At Coastal Hospice, we are here for you, and you can call us at any time on the number on your screen. Thank you once again for joining us. I am Lauren King, and have a wonderful rest of your day.